Welcome to the 2022 CGA-IGC podcast series, brought to you by the Education Committee. This season, we'll be hosting a virtual journal club. Each episode will highlight a recently published article that is important for the field of GI cancer genetics and feature an interview with one of the article's authors. Keep listening to find out more about the episode's host, guest, and featured article. Welcome to the CGA podcast. I am Dr. Thomas Slavin, and today we have two special guests. We have Rachel Hodan. She is a genetic counselor and clinical assistant professor at Stanford University in the Cancer Genetics Clinic. We are also joined by Dr. Kimberly Perez. She is a gastrointestinal medical oncologist and assistant professor of medicine at the Dana-Farber Cancer Institute. Thank you both for coming on today.
Thank you for having us.
Thanks, DJ.
And today we'll be reviewing a recent publication you both had, congratulations, in the Journal of Genetic Counseling, and it is EPUB ahead of print in February 2022. The title is Patterns of Germline and Somatic Testing After Universal Tumor Screening for Lynch Syndrome, a Clinical Practice Survey of Active Members of the Collaborative Group of the Americas on Inherited Gastrointestinal Cancer. I have heard of this committee, and we are excited to have two prominent committee members with us today. So to start, what were the major goals and findings of the article?
Thanks, TJ. So the major goals was really to understand a snapshot of CGA-IGC members and what they are doing in their current clinical practice. So the major goal was really to understand what type of testing is being done after universal tumor screening. Is that germline testing? Is that paired tumor and germline testing, and in what order and under what circumstances? So that was really the main goal. And we can talk a little bit more about the findings, but I think this was exciting because it was the first clinical practice survey of CGA-IGC members.
Is there anything else you found interesting from the results?
I think one of the highlights was that the CGA members were evenly split between wanting to order germline testing or paired tumor germline in the situation of a proband with mismatch repair deficient colorectal cancer, but without family history. And so I think it highlighted for us that there was not a standard way to approach these cases, and I think made it more interesting again to understand what are these CGA clinicians doing in these types of clinical situations.
And what led to the concept?
So we were tasked in the research committee to find a way to get the membership to collaborate. We're all coming from clinical practices where we're very specialized in the patient populations we're seeing. And so we determined that it was a perfect opportunity to perform surveys. So amongst the 2020-2021 research committee membership, we all brainstormed some clinical relevant questions and voted amongst ourselves what seemed to be questions that were thought-provoking and result in a project like this. And this happened to be the one that we all agreed was a good one to start with for this effort.
Well, it's nice to finally see it in print, probably after that initial meeting. It's always fun to look back and see how something started and where you wound up. And to that extent, I mean, what were you hoping really the major impact of the article will be?
I think we were hoping to better understand, in these more gray area clinical situations, really what are these experienced clinicians doing who are seeing a high volume of patients for hereditary GI risk assessment, and what are they doing in these difficult clinical situations? And so we used vignettes, as we described in the article, of clinical scenarios in which a patient had mismatch repair deficient tumor, colorectal cancer in this case, with loss of MSH2 and MSH6. And then we varied the specific clinical situation. So were they 50 or were they 75? Did they have family history or not? To try to understand what would these, again, high volume clinicians among CGA members do in these somewhat gray areas. And would they order germline testing as the next step? Would they do paired tumor germline, and in what circumstances? And so that was really the goal, is to understand in a situation where we couldn't talk in person as much in 2020, when we weren't seeing each other and saying, hey, what are you doing in these more gray area clinical situations? It was great to get a snapshot of what members were doing and thinking.
Was there anything that surprised you about the results?
I think the results definitely demonstrated that we all had something in common in the way that we were approaching this patient population. I think in the advent of this larger platforms or panels for germline testing, you think that you'd steer away from the use of family history or the impact of family history. But I think that the clinical history like that still was very meaningful in the answers that we were getting from the members that were surveyed. So that was, I think, a surprise, especially when the questions that we were asking were more of the different technologies and tests that are available. What are you really using? And it still always goes back to what we've always done in this field, which is talk to the patient. What's their background? How do we use that to move it forward? And I think that was a surprise that I think Rachel and I had both discussed was interesting.
And were there any challenges to finalizing the data?
The data was fairly straightforward for us. We did have the benefit of going back with a second survey of original respondents to clarify when they reported barriers, what were those barriers to, for example, ordering paired germline testing, if that's what they wanted to do as their next step. What were the barriers to actually getting that done? And so we were able to do a second follow-up survey, which was really valuable to understand that some of the barriers were things that you would expect. Of course, tumor not being available being an obvious one. And then lots of respondents said things related to insurance coverage, whether that's the patient not having coverage for it, not being able to go back and do somatic testing after they already had germline testing done, things like that. So I think if we added up all of the insurance related barriers, it ended up being like 75% of the barriers were related to cost and access.
Wow.
So I think that ended up being useful for us to understand how do we reduce the barriers going forward in this becoming standard of care of being able to offer patients both somatic and germline to clarify mismatch repair deficient tumors.
Something that to kind of tag along with that, but independent of what the survey topic was going to be, was that we conducted this in the midst of the pandemic, and we all had focused our abilities to communicate to Zoom meetings and email communications. And I think one limitation that we'll never be able to really test the impact was really survey fatigue. And so I think that was probably a challenge in finalizing our data, even though we went back to the initial respondents, was just that we got a reasonable uptake on that second survey. But I think we all wondered whether or not, if it had been kind of quote unquote normal times, would we have gotten more people involved because they weren't getting inundated with surveys during that period. And then the follow-up survey came as we were all fatiguing even more so from the pandemic and that means of communication. So I think that's, again, independent of the questions we were asking or posing, but I do think that probably influenced our final data.
And is there anything that you had to cut out of the article or something that you wish you would have added?
We also surveyed members in that same survey about impact on gynecologic care in the setting of unexplained mismatch repair deficient colorectal cancer for a female patient. And we did not include that in this article. And so that may be an important topic for CGA members in the future, or something that we may want to explore more. What do you do in that setting of guiding female patients about potential gynecologic cancer risk? And how do you determine that?
And that kind of leads into, anything else planned, or, what are you working on these days?
Well, we're excited that the 2022 Clinical Practice Survey is now out to members. So just a quick plug for our 2022 Clinical Practice Survey, which is out now and is going to be asking questions of members about universal germline testing for patients with colorectal cancer, and what is the current opinions of CGA members about the feasibility of starting a program like that.
What about you, Kim? Anything on your plate?
Probably too many things, but in direct response to this, not building anything off of this project. We had not anticipated that it was going to be something we were going to draft into manuscript form. We really were looking for it to be, at least during my time on the research committee, we were just looking for a way to ask questions of the membership, especially during the pandemic when we couldn't see each other face to face. We just wanted to keep the dialogue open. So I'm just grateful to have been part of that experience and excited to see that the research committee has been able to continue the effort.
Well, hats off to you both. It's nice to see it in print. And for those out there, again, please look at the Journal of Genetic Counseling, February 2022, and it's the patterns of germline and somatic testing after universal tumor testing for Lynch syndrome. Thank you both so much for coming on the podcast and all the stewardship for CGA.
Thanks so much, DJ.